So I'll be talking about the global impact of COVID, also the impact in orthopedic practice, and some effects on the musculoskeletal problem, and as already mentioned, some of the topics of interest to me. So beginning with the global impact, going over a little brief history about COVID itself. So this sort of disease started at the end of in the end of 2019, when a mysterious cluster of patients in the Wuhan province started suffering from a pneumonia of an unknown cause. So when they actually investigated, isolated this a new virus called which they labeled as the SARS-CoV number 2. So they tried to contain it, but unfortunately, by the beginning of the following year, started to spread over the borders, and the first documented case outside of China was in Thailand. And then by the end of January, the World Health Organization declared it as a public health emergency of international concern, and gave it the title of the disease COVID-19 in February, and then by March of 2020, we declared it as a pandemic, and then the whole world started to descend into chaos. So to date, COVID has now infected 256 million people around the world and has caused 5.3 million deaths. So how has COVID affected us in terms of the practice of orthopedics? So around about the time when the pandemic was happening, a lot of research and articles were being published, which was quite good. It helped add the information, and I'll try to summarize some of these. So what were the adjustments that were made? The adjustments were made across the board from the national level, with countries going into lockdown or stay at home, and also public health sectors trying to manage and modify their practices and diverting resources to where it was appropriate. And also in the beginning, it was a terrible time when even PPE and masks were all short, and there was a global shortage of things like this. So we were in a terrible crisis. But in terms of the local level of management, even then we had to reduce our services, downscale clinics, and some of our staff were also redeployed, and our shifts had to be adjusted. So I'm sure everyone is familiar with these type of implementations in their own hospitals, where like it was mentioned that the new hospital was changed to a isolation center for the level category 4 and 5 patients, I talked earlier just now. So these things have happened, and they are still happening in certain parts of the world as well. So in terms of orthopedics, how has our presentation of cases changed? In terms of the cases, you et al. Had performed a study in New York where they looked at 2 major hospitals that admitted trauma patients, and looked at 35 of the main orthopedic type diagnoses. And you can see that all over the different categories, there was a significant reduction in the number of presentations. And even in the most urgent cases of the major fractures, there were 4 out of 6 that were significantly reduced. So in terms of our operations as well, we had a reduction in the number of surgeries that we were doing. And this is also apparent all over the world, where you can see even from Chile to Malaysia to Hong Kong, the general consensus was that the number of orthopedic surgeries was reduced, and there was a proportionally higher reduction in the elective cases, in particular the arthroplasties and also like ligament reconstructions. So what about the trauma that was left? What were we seeing? Most of the trauma that was seen was essentially things that the end of the spectrum, where things were happening. Patients were falling at home, with elderly patients sustaining femur fractures and humeral fractures. All the low energy injuries, where maybe because of them living at home unattended, they tended to fall, they were not looked at. And also with children, there was a reduction in the number of falls they were having outdoors. And this was generally what we're seeing overall. So in terms of the trauma that was done, you can see that there was there was a systematic review that was done by Kumar Jain, published in the Journal of Clinical Orthopedics and Trauma. We looked at 6 studies, and they pulled together the results and found that there were 44 patients who were COVID positive during those period of study that were actually operated on. And you can see that out of the ones that were treated, there was a 36% mortality rate. Now, bear in mind, this was during the time before vaccines were actually out. So now it might actually be a bit better, but still that's quite a significant high number of mortalities. And as you can see here, the majority of trauma that happened were essentially the hip fractures. So with hip fractures, what is evidence of how we're treating them in during the COVID times? Excuse me. So Arafat et al. Also published in the journal, I think the Bone Joint Open, looked at a comparative study in the UK, and they studied the COVID as a cohort with positive and negative patients, and then a cohort from the previous year, looking at comparing the treatment of necrofemoral fractures. And you can see that there was a proportional increase in the number of fractures that were treated. But interestingly as well, there was a 36% mortality rate compared in the positive group compared to the negative group. And patients generally stayed longer in theater and also in hospitals. So necrofemoral fractures do remain a challenge. So in summary, in terms of how orthopedic practice was affected, the disease itself was a significant strain to health systems all over the world, causing us to alter our practice and restructure our workforce. But also the lockdown procedures and movement restrictions also changed, interestingly, the presentation of trauma that we've seen. But osteoporosis still remains a challenge, nevertheless. So in terms of our experience in Brunei, as you can see, this is the number of doctors we have in our main hospital. You can see, even during the normal times, we hardly have 20 doctors working, catering for the whole of Brunei. And then during COVID situation, 2 of the specialists were pulled away to various centers to look after, like an isolation center and the swab center. And across the board, the juniors have also been pulled to various responsibilities, including looking after vaccination centers and flu clinics. So we've been really running on a skeleton crew for some time. So yeah, and we've also had to cancel our elective cases, and we've only just been focusing barely on emergency surgeries, and ward closures and reduced clinics are also very much present at the moment as we are going through our second wave. So what are the implications for COVID and the musculoskeletal system? To be honest, there isn't much in terms of evidence, and it's still too early to tell in terms of any long-term results. But in the science behind it, the SARS-CoV virus gains entry into the cells by the ACE2 receptor on the cell wall. This receptor is more primarily found in the respiratory system, in the lung tissues, and that's why you get the pneumonia. But it's also found in these other organ systems as well. So in terms of the musculoskeletal system, Abdullahi looked into it, and he assessed the neurological and musculoskeletal symptoms in patients suffering from COVID. And these were the most prevalent symptoms. As you can see, patients did complain a lot on myalgia and also back pain. But it's also worth mentioning that in terms of once they recovered, a lot of patients also suffered from muscle deconditioning, weakness, and fatigue. But this is more attributed to being in the intensive care units for long periods of time. So another interesting thing is that Disser et al. Did a more scientific study of this, and they looked at previously published data on gene expression on target tissues for the COVID virus, and primarily can affect the muscles and also bones and joints. And the effect of COVID virus, they attributed to direct viral effects, so cell damage, secondary effects from cytokine storm, where there's immune response upregulation, especially interleukin-6, which can cause breakdown and bone density loss. And also in the early parts, intensive care units were relying on steroids to combat the effects of the virus, and that can also cause osteonecrosis and bone mineral density loss. Okay, so that is all I could find in terms of the effects of musculoskeletal, barring the old pain and back pain and muscle ache. So now an impact on training. So there have been some studies or some surveys that were done in Poland and also in the state in America that asked the trainees how they felt about working in the COVID environment. So the consensus is that there was generally a negative impact on the quality of training and the teaching, despite trying to convert to things like this where you have online teaching seminars. They still felt that they were not getting enough, and at the same time they were missing out on developing their motor skills. And there was also quite apparent that there was a lot of that affected their mental well-being as well. So in terms of the mental health, Sangeet et al. Did a systematic review looking at 44 studies which sort of tried to detect if there was any form of mental health issues with staff or healthcare workers working in the COVID environment. And as you can see from the table here, it comes at no surprise that almost a third of the workforce is affected by some form of mental health issues because of working the long hours with reduced capacity and also being in close contact with COVID positive patients. So in Brunei, essentially what we've also done a study during our first wave, which looked at similar things like this, where we surveyed the whole population of our doctors and dentists. We had a 40% response rate, and we looked at the depression, anxiety, and stress score, and also the OBI, the occupational burnout index. And it was quite eye-opening to see that almost a quarter of the workforce was suffering from some form of mental condition, and about 85% of the healthcare workers were also suffering from quite a significant level of burnout. Now, this is quite worrying for the health system when you only have at most about 800 doctors working for the whole country. So this is quite a big, about 600 doctors are already burnt out. So that is something that we need to try and address. So just to close off, where are we in terms of moving forward with COVID? So in terms of COVID-19, a lot of countries now are seeing reduction numbers of infections, and we're trying to keep things under control. But therein lies the issue that there is this, so to speak, hidden surge waiting to happen, where we are now having a tremendous backlog of our elective cases that still need to be done, and also trying to get back to full capacity in the clinics, and also looking at the budget and long-term supply of our PPE testing kits, our reagents, and also negotiation with vendors. And also we need to think about getting the population vaccinated. So there's a lot of things still to think about for policymakers. But there have been some guidelines that have been provided by Parvizi, which main sort of take-home messages would be that when we start going back to the new normal, we need to prioritize our cases on what needs to be done first, and then also make sure we have protocols in place to reduce transmission and how to deal with positive patients, and then also supply of PPEs, and make sure that the workplace adaptations are in place when things try to start again. Okay, so that is pretty much it.